I want to thank the organizers for this invitation to speak at today's meetings. I'm going to be talking about ultrasound and peripheral arterial interventions and how ultrasound can help you when you're treating patients with vascular disease. These are my disclosures. So I'm going to focus on two common areas where ultrasound can help you in terms of peripheral arterial interventions. One is CTO crossing, and the other one is access or access options. So let's start with CTO crossing first. You know, with CTOs, one of the difficulties is calcium, and we know that about a third of the lesions above the knee have calcium, whereas below the knee they tend to have about 75% of the time they have heavy calcium burden. And the problem with calcium is it makes it very difficult to get through these chronic total occlusions. And if you've never seen a CTO, this is what it looks like. This is what it looks like under a microscope, actually. If you look at these black arrows, you can see that it's pointing to the small microchannels. And this is what you're trying to get through when you're trying to traverse a chronic total occlusion. And this is the reason people talk about guide wire escalation, various sizes of guide wires, different features of guide wires, and so forth, because this is what we're trying to engage and cross when we're getting through chronic total occlusions. So the difficulty with CTOs is that they result in prolonged procedure time, increased radiation exposure, higher contrast volume, a higher chance for dissection, fistula formation, and perforation, and a higher likelihood for stent placement. And there's about a 20% or greater failure rate to cross a CTO, depending on the experience of the operator. And so you can see why chronic total occlusions are really the rate-limiting step when it comes to treating patients with peripheral arterial disease. A couple of important ultrasound signs to consider when you're looking at specifically at tibial vessels is what's called the white stop sign. This was described by Dr. Mustafa and Dr. Saab, and you can see that on the left, that's a longitudinal image of a tibial vessel showing you a dense calcification filling basically the entire lumen. And on the right, you can see what it looks like in the transverse plane, along with some associated veins around this occlusion. And what makes it difficult is that crossing these can sometimes be impossible, as you can imagine. So another important ultrasound sign is called the Janali gap. Basically, if you look at this tibial vessel, you can see the red arrows are showing dense calcification involving the arterial wall, whether it's the intima or the media. And the white arrow is showing you basically a gap between these calcifications. That's the so-called Janali gap, and that's an area of a negatively remodeled arterial wall. And so what do these signs all translate into? Well, what it shows you is this. It results oftentimes in a failure to cross the chronic total occlusion, or CTO. So as you can see here, this is very difficult to get through, and I wasn't able to cross this occlusion of the common plantar artery, which was occluded. And I think you can see the dense calcification along the course of the medial and lateral plantar arteries as well. So now let's look at another kind of a real-world case. As you can see here, here's a distal right SFA occlusion. And what you want to do when you're looking at these angiograms is you want to do what's so-called cap analysis, because that's going to help determine, do I need an access from above, from below, or just above, and what's my likelihood of being successful in terms of crossing these. As you can see here on this angiogram, the proximal cap of this chronic total occlusion has a large vessel or collateral that's coming off of it. And as such, if I engage this with a catheter and guide wire, I'm most likely going to be subintimal from the beginning, which means then I have to re-enter distally, as you can see here. You can see that the distal cap, which is the image on the far right, it's showing you, again, a complex cap where my catheter and guide wire are likely to slide off the apex of that cap and become subintimal or stay subintimal. And so re-entering into the true lumen becomes a difficulty. So let me show you an example of that. So if you've never seen a subintimal recanalization, this is what it looks like. As you can see here, this is basically a chronic total occlusion of the distal SFA. We're doing a subintimal recanalization. And as such, you can see the catheter and guide wire system spiraling around the vessel. And so you know this is subintimal. And ultimately, it requires a re-entry device to get through and through access in order to complete therapy. And then we were able to basically stent this. And as you can see here, basically we have a nice angiographic result, but it did require stenting because it was a subintimal recanalization. But let's look at another example. What about doing something with ultrasound? So again, here's another patient with a distal SFA or above knee popliteal artery occlusion, and you can see now under ultrasound that basically we have intraluminal recanalization. And you can see here the ultrasound really shows me the layers of the blood vessel or the artery. It allows me to stay intraluminal. I can tell when I'm basically perforating out or when I'm basically dissecting and so forth. And so we were able to achieve a nice intraluminal recanalization in this case. And as you can see here, that resulted in no stent having to be placed, which is obviously better for the patient in the long run. So let's look at this case. It's a patient with CLI who has a ulceration in the great toe distribution. We knew that we needed to open up the anterior tibial artery and likely the dorsalis pedis artery in order to achieve really optimal healing in this case. You can see the angiogram shows you a proximal anterior tibial artery occlusion with a complex proximal cap. And so as a result, I knew that I would need either dual access or possibly single access from below, but obviously we like to do dual whenever possible. And so as you can see here, I achieved pedal access in this case. You can see I'm doing a classic recanalization. But what we did instead is we decided to use ultrasound. And as you can see here, this really shows me the guide wire, the catheter system, and allows me to see the vessel walls so that I can try to remain intraluminal. And so that way, if I'm starting to dissect into the wall, in other words, a subintimal recanalization, or perforate outside the wall, I can see it very easily and I can retract the system and then try it again. And so as you can see here, we were able to achieve intraluminal recanalization all the way to the proximal cap, but because it was such a complex proximal cap with multiple branches coming off of it, it really required the catheter and guide wire system to be used from above. And then ultimately I was able to achieve through and through access. And then we obtained a nice 3-vessel runoff, and ultimately we're able to achieve healing in this case. And you can see where the red arrow is showing there's a nice angiographic wound blush. So let's look at this case now. So here's another patient that has CLI. We've got a flush occlusion of the right SFA or a near flush occlusion. And you can see we have a nice, robust, deep femoral artery. And what we want to do when we do this recanalization is be intraluminal at the proximal cap. And this is where ultrasound can help us. So if you look at the ultrasound image, you can see I have my catheter and guide wire system in the center of this proximal cap so that I know when I start my recanalization, I'll be intraluminal at least at the beginning. Where I'll be at the end, that's a different story. But at least we'll know we'll be able to protect the deep femoral artery in this case, and ultrasound really allowed me to do that. And as you can see here, we only had to stent the proximal aspect. We stayed out of the common femoral artery and away from the origin of the deep femoral artery, and we're ultimately able to deliver therapy, as you can see here. So here's another case. We have another CLI patient with a above knee popliteal artery occlusion. And in this case, instead of using intravascular ultrasound, we used EVUS or EVUS, extravascular ultrasound. And where it helped us here, it helped us for 2 reasons. One is we were able to optimally size the artery in terms of determining balloon diameter and stent diameter. And then after the stent was deployed, we were able to see that the stent opposed the walls normally, and we had an optimal stent expansion and stent results. So another area where ultrasound, in this case extravascular ultrasound, can help you when you're treating patients with peripheral arterial disease. So let's look at this patient. Again, CLI patient, flush occlusion of the right SFA, reconstitutes the above knee popliteal artery. And you can see, in this case, the red arrows are showing you the chronic total occlusion of the right SFA. You can see a white line, which is the big red arrow that's pointing to the proximal cap. So that's the origin of the SFA, and you can see I'm in the center of it. So again, this allows me to avoid injuring the deep femoral artery or the profunda, and allows me to stay intraluminal at the beginning of my recanalization. Where I end up obviously depends on how successful I am at maneuvering through this occlusion and re-entering distally. And then this is another example. Once we got distally, you can see that basically the catheter and guide wire system from above and below are in two different subintimal planes. And so they're not communicating. In this case, we used ultrasound or EVIS like we talked about, and we were able to see the catheter and the wire, as you can see on the image on the right. And that ultimately allowed us to basically make sure we were in the same plane and ultimately get the catheter guide wire system into the catheter that was placed from above, as you can see here. So another area where EVIS, in this case extravascular ultrasound, can help you during a peripheral arterial intervention. We were ultimately able to do good vessel prep and optimize our angiographic result. So now let's talk about where ultrasound can help us in terms of access. You know that there are many access options today, whether it's the wrist, at different places in the arm, such as the brachial artery, obviously the leg, meaning the common femoral artery, the thighs, as well as the ankle and foot area. So we have multiple access points now when it comes to treating patients with peripheral arterial disease. And as you can see here, this is an example of an antegrade access. So you can see in the top left image, there's the common femoral artery. My goal is to access the common femoral artery there and then gain access into the into the SFA, as you can see like that. And if you look on the image on the top right, you can see I've gotten access into the common femoral artery. I was able to avoid a densely calcified area of it, the blue arrows, which are showing you the calcification. And ultimately on the bottom left, you can see that my guide wire was maneuvered or manipulated into the SFA. And this is really what it looks like when you're looking under ultrasound. Obviously, you know, I would probably do this transverse, but sometimes once we're close, we'll switch to the long access view to allow us to see exactly where we are. And then basically once we get access, we can use ultrasound to maneuver away from the deep femoral artery and make sure our guide wire goes into the SFA. So let's talk about pedal access in this case. There are various forms of what they call pedal access. Obviously, we can access the anterior tibial artery, the dorsalis pedis artery, the perineal artery, as well as the posterior tibial artery. And these are examples of what you can expect when you have classic anatomy in a patient. Obviously, you want to access as Obviously, you want to access as distal as possible, mainly because as you go more proximal, the compartments around these or encompassing these vessels become larger. And so the risk of hematoma, bleeding, compartment syndrome become more significant as you move proximal in the leg. And so you want to try to access as close as possible or around the ankle joint or distal. There are various products out there, obviously different companies that make sheaths and guide wires and balloons and stents that can be advanced or placed via the pedal access. These are systems from companies like Cook and Terumo, etc. There's various ones, and you can use any of these or another company, obviously, for your access. So here's an example of what it looks like fluoroscopically. If you look in the image on the left, you can see that's access into the anterior tibial artery. And then you can see that, actually I'm accessing the dorsalis pedis artery into the anterior tibial artery. And if you look on the top right, you can see there's my sheath and catheter system. The patient's toes and foot point to the right. So I'm basically accessing the dorsalis pedis artery to go up into the proximal aspect of the leg. And then below that, you can see the red sheath and catheter system, basically where I've accessed the posterior tibial artery, just to give you some examples of pedal access. If you've never seen the tibial vessels under ultrasound, this is what they look like. You can see here we have the anterior tibial artery on the top left and its corresponding veins. We have the posterior tibial artery below it, again showing you real time with compression. And these are normal, healthy tibial vessels, which is why it's very difficult to compress them because the perfusion pressure is normal. Obviously, when you're dealing with patients with peripheral arterial disease or even this most severe form of CLTI, you have to note that sometimes the artery will have basically very little flow, and you'll be able to compress it easily like a vein. So you always want to make sure you know which ones are the arteries and which ones are the veins. And if you look on the top right, you can see that's what a perineal artery looks like. And a lot of times, because it's deeper, sometimes it's harder to see, and it's a much more difficult access. So why pedal access? Well, the main reason is because we know that patients with PAD or CLTI have CTOs. They have chronic total occlusions or chronic total obstructions. And getting through those CTOs is really the rate limiting step when you're treating these patients. And so pedal access oftentimes can help us get through a CTO because the distal cap sometimes is less calcified. It tends to be softer, and oftentimes you can cross it intraluminally without going subintimal in many instances. Obviously, morbid obesity, when you don't have easy access to the groin, or patients with a hostile groin where they've had prior radiation or multiple surgeries, you can avoid those areas and use pedal access to your advantage in those cases. Severely diseased CFA obviously makes sense. You don't want to access that vessel if you don't need to, especially if they may be going for some type of surgery later on or after your intervention. In patients who are unable to lay flat for whatever reasons. And obviously when you have patients that have an acute angulation of the aortic bifurcation, secondary to either congenital variation or because they've had a prior aortobifemoral graft or a stent graft, then getting up and over to go to the opposite leg sometimes is very difficult. There's a technique that's been described by Dr. Mustafa and Dr. Fadi Saab, called the Tami Technique. It stands for Tibiopedal Arterial Minimally Invasive Retrograde Revascularization. This is really the ability to treat arterial disease from below without access from above. So you're basically fixing everything from a pedal access or a tibial access. And so this is something that has been described, and many operators today are doing this. The advantages of pedal access in general is that it's quick and easy. You get quick and easier hemostasis. Oftentimes less complications compared to antegrade CFA or SFA access, quicker time to ambulation, quicker discharge. Sometimes you have less procedure time, and the overall fluoroscopy time and contrast that's used can be significantly less because you're working close to where the abnormality is, and so you can oftentimes also obtain better image quality. There are many ways to access the tibial and the pedal vessels. Obviously, one of them is ultrasound. When you're looking at these vessels, we recommend, as the left graphic shows, that you access in the transverse view at about the 12 o'clock position. And then once you feel like you're either on top of the arterial wall or you've gone through the wall into the artery, then you can convert to a longitudinal or sagittal view so that you can see the needle, you can see the arterial wall, and you can see your guide wire being advanced into the lumen. Fluoroscopy is another way to do this, as you can see here in this patient who has heavily calcified tibial vessels. And so in this case, you can see we use fluoroscopy. We were able to puncture through the calcium and ultimately gain access with our guide wire. Finally, you can use contrast or angiography guided access. This is using really the classic Seldinger technique where you've got contrast in the anterior tibial artery. There's a double wall puncture. You retract your needle until you have extravasation of contrast, and then you're intraluminal and you pass your guide wire. I think today most of us as peripheral arterial disease or even CLTI operators would really use a modified Seldinger technique where we try to do a single wall access and not a double if we can help it. Another access that's important and can help you is, again, digital artery access. And ultrasound is very important when trying to access these vessels. You can see here on the left, a lateral or common plantar artery has been accessed, a dorsalis pedis artery has been accessed, and on the image on the right, you can see a digital artery as well as a tibial vessel have been accessed as well. So this is something that is really a lot of people are doing in kind of these limb salvage cases, is accessing the digital arteries. So here's a case I can show you. You can see here's a CLTI patient. It's got a non-healing ulcer on the great toe, prior amputations of the 4th and 5th digits. You can see I have digital artery access, and I have also access of a tibial vessel. And angiographically, you can see there's really nothing below the knee joint, nothing really below the ankle that's significant. I was able to get access from above and below and use various techniques to cross the chronic total occlusion of the dorsalis pedis and anterior tibial artery. I did good vessel prep, ultimately angioplasty, and was able to achieve a nice angiographic result with inline flow with a single vessel into the foot. Now, is this going to heal this patient completely? No, of course not. But this gives us some time so we can bring the patient back on another day to try to open up another tibial vessel if we're able to. So I want to show you now a very interesting case. This is a CLTI patient. You can see they've got chronic ischemic changes in their foot with hairless and shiny skin, thickened nails, and a large area of ulceration involving the lateral dorsum of the foot. You can see angiographically that there's really not much below the knee or below the ankle. We do have reconstitution of the distal posterior tibial artery, which is really useful in this case, but we really have nothing in the foot of significance otherwise. So I knew that I would need dual access. We obviously had access from above. I accessed the distal anterior tibial artery, which is occluded. So this is the so-called Schmidt technique that they call it. But I used ultrasound to confirm that I was intraluminal. And you can see here on the left, fluoroscopically, there's my needle and my guide wire. I ultimately switched out for a sheath and a catheter, and you can see that there's my catheter, there's my guide wire, showing that we're intraluminal part of the way. And this is what it looks like under ultrasound. You can see that in the middle video, I'm showing you what the anterior tibial artery looks like when I'm following it transverse. You can see the guide wire is in the center of this occluded vessel. And so that gives me confidence that I have an intraluminal access and crossing of this chronic total occlusion. The video on the far right shows you basically the same thing, but in the sagittal or longitudinal view. And finally, this is what it looks like with intravascular ultrasound. So once I crossed, I used IVUS or intravascular ultrasound to really visualize my guide wire and the arterial wall to look for calcification, plaque morphology, age of the plaque, and also to see, am I completely intraluminal or did I go kind of spiraling in and out of the subintimal space and back into the lumen and so forth. And this has significance in terms of how I'm going to do my vessel prep in this patient. And you can see here ultimately after crossing 2 vessels and doing good vessel prep and angioplasty, etc., we obviously had some nice hibernating vessels in the foot as well. I was able to achieve a nice 2-vessel recanalization with a nice angiographic wound blush, as you can see in the red arrow on the far right. And we were ultimately able to get significant healing over the course of about 12 months, and hopefully with continued wound care, etc., we should be able to get complete healing. So please subscribe to my YouTube channel to see more content like this, Dr. Tamala's Vascular channel, and follow me on Twitter @SriniTamala, and thank you for your time.